Hello and welcome to the Circuit Breakers interview series. I'm your host, Steve Semler at FocalPoint Coaching. Today, I'm joined by Mat Johnson, who's the founder and CEO of GeaCom and Althing, a couple of Minnesota companies with a lot of transformative and actual more than innovation, invention work done here around devices and processes and systems that transform and enhance patient engagement experiences for medical enterprises. Mat, thanks for joining us. Would you like to kick us off with a brief background about you and your company, your companies?
Sure. So my name is Matthew Martin King Johnson. The company GeaCom was founded in 2007 to address the patient variable in healthcare. And generally that means the point of contact between patient and health facility is that individual entering into service. And that's a variable that's not well managed. Whether the patient has a specific issue, the ability to communicate it well, what language they speak, what their literacy is, a multitude of variables that really historically haven't been managed well, that disable downstream process improvement for health services. So our entity GeaCom determined that its purpose would be to manage the variable of the inbound patient and the variable of the servicing enterprise so that we can normalize that experience. So in spite of language, literacy, culture, gender, background, and presentation of issue, there is a predictive process in terms of time and effective transference of information to the medical system. And concurrently, in spite of what point in the shift or who is on shift, the performance of that medical system will be equivalent. The outcome of this is a complete civil rights capable encounter in a medical environment for the first time in this country. And ultimately, from that stems a significant amount of process and value, and its beginning is simply normalizing that encounter.
Yeah, and making it equitable and possible to have that equity where it really was simply not. And so this is coming about, as I understand it, through a combination of device, hardware, software, and process work. Can you say a bit more about how that came to be?
Well, we start with what is our medium that we operate in now? Where is healthcare driving toward, and where are those changes having deleterious effects that ultimately are creating this inequity that is untenable, right? So we can get into the depth of inequity, but rest assured it's horrific. If you're from a specific background, the likelihood of you having a quality health encounter is very low. The daily death rate as a result of significant miscommunication that could be easily avoided is over 500 individuals a day. The suffering levels are really astronomical. It's the number 3 killer in the United States is medical error, and that's not hospitals making mistakes, and that's not patients making mistakes. It's the interaction of the two, creating an environment where those issues can exacerbate and become downstream problems that ultimately end in fatal, outcomes. So what is the medium? What is causing this? Well, centralized care requires a volume of individuals to come to a certain location and process in a certain way that matches with records and with regulation. That doesn't align well with how human beings work. And this is just really the start point. We evolved and we live here today on this planet. We are having this conversation and people are watching us because their parents weren't so obnoxious that they couldn't reproduce, and they weren't so obnoxious that they couldn't cooperate and feed themselves and clothe themselves and stay healthy and safe. And that's really the core of what we need as a species when we in a very important engagement, right? For example, there are 212 complex emotional states that are identified from the brow line alone. So just this part of your face, it's happening and you don't know what's happening. It's helping you determine trust, compliance, attentiveness. These concerns are at the core of who we are as a species. When we go into a medical center, we're leaving our comfort zone. Now, the medical provider may feel like they're in a factory and they're seeing person after person and applying best practices to the best of their ability. However, I can talk about some of their challenges, but that individual person is not at their best. And they're relying more heavily upon that evolutionary biology for successful ability to navigate. And everybody who's hearing me speak right now has had an encounter where they have some form of amnesia to what happened. because they are so muddled in their brain and the process is so incongruent with their natural processes that they can't recall things correctly. And this is a problem. So the medium, if there's paper and it includes a list of things, check off what you may have as a historical health issue, your past medical history, your social history, and these other items, it is fraught with errors.
Mm.
In particular, this is form blindness on even the medical practitioner side. We're not seeing a person face to face, eye to eye. We're looking to see a doctor. We're seeing everything but a doctor in this process. We're seeing a waiting room after a waiting room after a waiting room. We're seeing other people in those waiting rooms. We're pulling in a lot of sensory input, and we're functioning in a way where we're still struggling with pain or anxiety, even for a conventional visit. This is a problem. So the medium of a phone, or tablet, or a piece of paper, or a thing that works well with a digital record is a medium that doesn't work well with human beings. And so our start point was, how can we create an effective communication mechanism that's reliable from both sides of this equation that leverages evolutionary biology? And there are two particular parts of this that are relevant to what we do. One is communication theory. So communication theory is a deep science of how to convey information from person to person most effectively without loss of data and loss of meaning. It's a very sophisticated process, but it leverages well when we can match our race, our gender, our background, our speech cadence. These are things that we need as part of our psychology. How do I recognize an authority? How do I know I'm being heard? How do I know I'm conveying that? How can I achieve the ability to understand what they need from me? And so that is what we provide the patient, is communication theory encounter. So when you walk into a facility with our technology, like an Althing Clinic facility, the first thing it'll identify your race, gender, background, and language. And then it'll quickly welcome you to Althing Clinic. It will have a person who matches you, someone who's white, my age, in mid-50s, walking onto the screen and holding this handheld device called a Fraser. And that individual will literally do the best practices communication encounter and say something along the lines of, welcome to Althing Clinic. You are now connected to your care team. As you and I work together, everything you share with me will be communicated directly to them as effectively as possible. And those care members will be with you the whole time. You will never be alone. And I'll ensure nothing happens without your fullest knowledge and consent. Let's begin. Literally within less than 10 minutes, that patient is onboarded, past medical history, social history, review of systems, versus the convention, an average of over an hour and 20 minutes before they even see a person. And so on the flip side of the equation, though, communication theory may get in the way of a provider's ability to process multiple patients and look for meaningful information to provide a care plan. And so as Fraser and the Kitsune headset is working with the patient privately, and by the way, patients have a 96% preference for this over convention. So it's not a guesswork for us how well this works. The provider needs to know who's in that waiting room, but if I'm the nurse, I don't need to know what the doctor needs to know. I have different information that's important and relevant to my job. The doctor has other information important and relevant to their job. The lab has other information important and relevant to their job. And getting into the barriers to their communication too, is the EMR needs this information, the electronic medical record. So as the patient works on the platform, they are actually charting their own record. So their entries for where their body pain is presented. They come in and they have a stomach pain, and it's identifying that's where it is, and it's zeroing in where it is and how long it's been going on and how it presents. The nurse will hear, for example, patient in the waiting room has abdominal pain, level 8. You will go to the patient's side and they're prepared for pain medications. The doctor may hear patient has indicated stabbing pain, lower left quadrant, onset 3 hours ago, no history of surgery, steadily getting worse, and some other things that are relevant to them. And the whole time the record is being fed. Now, if this patient is also a Laotian, I'm a Laotian woman coming in for care, your patient speaks Laotian, your patient is with a companion, you may need to speak to that companion before you speak directly to the patient. So it'll also provide cultural cues to make that encounter with that patient more effective. And so the key points here are communication for the patient, communication theory for the patient. They're never alone, and it's equivalent. If I'm in a dominant, gender, dominant culture, dominant race, dominant education person, and I have a quality encounter, and then that Laotian person comes in, they don't speak English, they will have the exact quality encounter. If I'm a provider, it's irrelevant the background of those individuals. I'll be provided for the information and the way best to communicate with them. And then there's another portion of our patented technology is, as I formulate the care plan, it will tell the provider the likelihood statistically of that individual patient, their culture and background, in the array of potential care plans, which they're more likely to be able to comply with effectively.
Interesting.
Long answer to a simple question, but at the core, we summarize it by saying we afford people their full civil rights in care, and we help make the providers more effective with the patients, right?
Yeah.
So,
I would imagine a huge amount of data must go into that.
yes.
How do you get all the cultural variables and the medical position variables and all the things in there?
Well, I'll start with what is it worth? What is it worth to us? What is it worth to us to understand how to work with a low Asian person? It's worth everything. It's that person's life. It's the speed at which our providers can administer care. It slows the entirety of a health system when they have patients who cannot flow well. That's why we have wait times. That's why we have what we've learned to cope with, but nobody wants. Nobody wants a waiting room and a sub-waiting room. And I mean, it's just ridiculous that this is literally what we're doing here. And this point in our civilization is nuts. So when you start with what is the value of the output, then it sets you up for what's the value of the development. So spending time with each of those cultural groups, looking at what categories of service are needed and what are specific to their culture. What is authority in Laos? What
Hmm.
is gender roles in Laos? And can a person say, yeah, but I'm not one of them. I'm not that person. Yes, the patient has an opt-out option. There's also a cultural engagement that we have separate from everything to say, this person's not presenting as normal. Let me do the cultural triage, and it'll reset them to the triage relevant to them. I take, for example, really an important part of our culture that sees disparity is the African American population. There isn't an African American population. It is a mosaic of unique subpopulations that need different types of care. The question of how we get all of that information into this platform, technologically, it's got multiple terabytes of memory, but practicality of how do you have all these languages and all these cultures and all these subcultures? You have a Laotian female and she is from Laos. You can kind of narrow down on the fact that the way their culture works, the way their systems work, the way their language works, and share that culturally relevant information back to the provider. You could ultimately try this in a big, country like India and have so many cultures that you have to sort it through. We use techniques to localize to the region and to actually, many times, the township that the individual came from. And inside of that zone, you have, yeah, go ahead. So the question is about all of the data and information that has to exist on the platform to be able to meet the variety of human beings that might enter into a medical facility. So technologically, there's plenty of space. There are multiple terabytes on these systems. The data exists on the system. It's not streamed through the cloud. And every one of those language and culture sets lives on the platform. Each of the platforms has all that knowledge. What is the value of that knowledge is where you start before you produce it. What does it mean to have a proper encounter for a Laotian or a proper encounter for an Arabic speaker? It means multitudes of millions of dollars if you put it monetarily in terms of the cost to health systems. For the patient, it's priceless. For our civil rights requirements in this country, you cannot put a price on the ability to equivalently meet each individual person. This is an unmet need. We're the only entity who has taken on this challenge and successfully accomplished an application of this. So when we do a set of languages, underneath that set of languages will be a multitude of faiths, of subcultures, of groupings. And the interesting thing is these individuals who take it upon themselves or are forced as a result of political strife to move to other places tend to move in groups. So when you enter into a place like Health Partners in St. Paul's Regent's Hospital, you're ultimately looking at roughly 12 dominant language to cover 99% of the patient population. And then subcultures under there might be in the range of 70 to 80, but they have so much commonality. And so you start with that finite amount, and then you start with the application. Is it the ER? Is it inpatient? Is it pain management? Is it ortho? And then you start subsetting that into how best to communicate and work the workflows. So, and there's a variety of complexities even in our own country. And I would say that making culturally relevant and effective communication for Americans from different races, classes, and backgrounds is equally as relevant as working with individuals from other parts of the world.
Yeah, yeah. So from a business perspective, what were a couple of the biggest challenges to making this all happen?
Well, first, the difference between an innovation and an invention.
Mm-hmm.
So an innovation is when you do something that you can proxy. Like I make ice cream, but my ice cream is sweeter with lower calories. So I have a proxy. Look at this, and this is this plus this. Or I provide automobiles that have hybrid, but they're hydrogen. And so a person pictures this incredibly well. Okay, I get it. And you have a little bit of work to do, and it makes it very easy to convey that. When you're doing something new to the world, you need to break the proxies. You need to say it's not like a tablet. It has nothing to do with a tablet. It's literally impossible to do this on a tablet. And despite all of our efforts, the incredible, powerful marketing teams at Apple and Samsung convince people that their systems can do things that not only can they not do, but it's dangerous to consider doing it with those platforms. And so the number one challenge for taking on what we did was first, how to effectively communicate a sophisticated change to the world that has no proxy. And to this day, we struggle with that specific challenge over and over again. Secondarily, making hardware that is orders of magnitude more complicated and more industrial and more medically grade than anything made in this country, including Apple, which is not made in this country, to be clear, is on itself, we are the only entity in the country that does it. And so here we are, this small entity creating the most advanced medical technology in the world, I would venture to say. And I know a lot of people listening to this will say, well, this guy's got, drinking his own Kool-Aid, but no, look into it. You'll see, it's not easy to do. You got supply chain, you have, people like Micron might not want to sell to a small company. You might have difficulty sourcing screens because some big entity like Apple thinks that it's a competitive advantage to buy all screens, so no other entity can have them and compete with them. So you have predatory activities in the market space. You have disinformation. So just making the hardware itself is quite a challenge. And to make a hardware that has a physical aspect to it that creates comfort, that creates stability, that merges with communication theory is a whole nother layer of human factors that haven't been well investigated. And so you're pioneering not only new hardware and new technology, but new techniques of physical interactions between human beings and technology. So that would be the hard stuff. The next layer of that is change management. The medical world is entrenched with Fortune 500, or I would venture to say Fortune 50 companies. It's a very sensitive space that has an entrenchment that makes their failures persistent from generation to generation. And, it's part of what keeps them reliable and is part of what keeps them difficult. And that's a challenge that is hard enough for a large company to take on, much less a small company.
Yeah. Where have you found some of your biggest successes in getting past those challenges and hurdles?
Well, thanks for asking. People, there isn't a medical system in this country that doesn't have someone who really cares deeply about the ethics of care. They know what those headwinds are, and they're willing to be the internal champions. It takes those types of people to drive new ideas, and many of those, despite their greatest efforts, have hit such headwinds they could not successfully bring it together. And I think it's hard on them, but there's a percentage of people excited enough for this type of change that they get on board. And some medical systems are designed to innovate. Most of them are designed to be fast followers. So navigating those who are designed to innovate and getting their buy-in and application is really the key.
Yeah. And so that's one of the strategies that you found that is successful and that you're pursuing now on the Althing side, Althing side.
When we ran into COVID, we had been making some headway, and you should be able to walk to a medical center and say, "You ready to be civil rights compliant?" And they should be, "Yeah, we ready. Let's get started." It's not that simple. And I
Yeah.
would say that my disappointment in the fact that it's not that simple can't be overstated, but the complexity of what the customer is facing is something that I also don't have the depth of knowledge to convey well. If they could, they would, and some do, right? So when we had COVID, a lot of technology suppliers, especially those smaller non-entrenched suppliers, got put on hold, right? And
Yeah.
I think there's definitely an amnesia around COVID. We were supplying a medical center in Robbinsdale, Minnesota, and running sections of their COVID response and ER. And we didn't know if our staff was safe. We had, no admittance for pharmacists or hospitalists, and the staff that was in there was gowned top to bottom, taped in. We were in there supplying that, and it was a terrible, terrible time for the country. And there wasn't clarity on when this would be, when and if this would be resolved. And it was a shakedown in the fragility of our medical systems. It was a real shocker for the number of people who died and suffered in ways that people don't appreciate. The adolescent wings of behavioral health facilities emptied. What does that mean? No kids were having problems? No, it meant they were suffering with zero help. Individuals who had to have colonoscopies and had cancer progressing didn't get that colonoscopy. Individuals who had therapies and identification that should have happened didn't happen. People died that weren't COVID related as a result of the fragility of our medical systems. It was a collapse that cannot be overstated. It was still, our medical systems are reeling. The state of Minnesota, I think it's over 85% of our hospital systems are running in the red. A large number of hospitals have closed recently. The consolidation is causing rural access disasters across this country. If anybody's interested, take a look at the situation in Wisconsin. Our neighbors cannot get to health services within, a 2-hour drive. There's going to be senior citizens having a fall, suffering for an additional 2 to 4 hours because they cannot get to an emergency care system. This is a disaster, right? And we had just made all this headway, and we hit this hard stop, except for where we were supplying. But we had been doing a program in school districts concurrent to our supplying the medical enterprise space, where we were helping new families navigate the American district and school culture. Like, why do I have to have an inoculation? My kid has epilepsy. How can I send them here? And how do I know they're okay? And we found our way to what is now, post-COVID, the largest health epidemic in the country today, and that's adolescent behavioral health. And we discovered that this was deeper and more affecting than we had ever imagined, and that we had a way that we could create a direct consumer model that would be the ultimate example of our site systems, again, communication information theory. So our civil rights health services, undiluted by convention, literally pure civil rights health. And so we founded a clinic set called Althing. We located our first and largest clinic in Austin, Minnesota, where there are 53 languages spoken in the classrooms and 103 languages spoken in the community. And a community that is very welcoming and really good at immigration, unlike many communities in our country today that struggle. This is one that is vibrant. I'm very proud of the city of Austin and what they do. And that enabled us to go from the ground up and create a health experience that was the best possible that we could develop for equivalent healthcare across all demographies and literacies. And today, we are the only health system in the country operating a complete civil rights service. Anybody who walks in our door sees a provider in less than a minute, authors their own chart in any language, literacy, culture, and background, and our average convenience care and primary care encounter, so the top 25 chief complaints, are served and have a discharge and care plan in less than 22 minutes average.
Wow.
So equity records, speed records, and a really fine example for entities in this country that can go visit this facility. We have an open door policy for enterprise because our number one desire is to improve health equity, one of our biggest impacts. And there's a number of health systems that have taken up that offer and are beginning to understand how this works and adopt. But this second part where I kind of started toward was the behavioral health epidemic. How do you get into a school district when you know more than 30% of those students have clinical levels of depression, when you know that the suicidal ideation and self-harm rate is in excess of 15%, in many cases as high as 20% amongst subgroups inside of that district, when there are strict statutes and there's no budget, schools can't pull money out, you can't live off of grants, referendums don't work. Well, how do you do that? And we determined that we were going to take that on. And the first job for us was to develop a mechanism that would operate within statute to enter into a district. And we're now able to provide a private HIPAA covered behavioral health encounter for every student 12 years old and older, and every staff member in a school district in a program, an application from Althing Clinic called AIRS. It's an assess, intervene, refer, and service. So it's a process following strict federal guidelines and health processes to effectively identify, address, and intervene where health concerns exist and assure 100% referral rate for those in need. When you're seeing over 30% of the students needing further help, that's a pretty significant claim. But we've got thousands under our belt already. We have hundreds of thousands ahead of us in this coming year. And this is really, the Althing health side is really, really changing the landscape in behavioral health right now. And it's something I'm very proud of.
Yeah. It's a new model. I mean, it's higher from thinking onward, supported by what you're able to do also on the device side.
Right.
So it really is a holistic approach.
Yeah. So one of the challenges is big health issues, like 30% of adolescents is we're talking millions of kids. Where are you going to get the millions of providers to do this? A qualified health encounter requires a face-to-face encounter. How do you possibly do that? Our site systems, combined with our backend services, create a 10-to-1 force multiplier that meet HHS requirements. So it takes significantly fewer providers to see face-to-face a higher volume of individuals within the confines of regulatory application, right? So I'm not guessing, this is what we do. There's no third party, we're 100% vertically integrated. Technology, staff, application, every operating system, everything vertically integrated. And we're able to do schools of as many as 15,000 kids, everybody 12 and older in staff in 4 days. And everybody will have had a qualified health encounter with a provider. Everybody who is entitled to an intervention will have a same day, vital point, same day intervention face-to-face with a qualified health provider. And those individuals who can't continue on with supports in a care plan and they need a qualified referral, 100% of them have been placed. So again, that is Althing Clinic and its subproduct is AIRS. And this has a national potential, and that's really where we're doing significant growth today.
Yeah, it's extremely impressive. What's the next thing over the next 12 months?
Well, we're going to scale to over 500,000 encounters in the next school year. And we're going to continue to partner with the payers. So people like Blue Cross or UCare or Cigna and the others. What they have researched, their actuaries have discovered, is the time from onset of behavioral health concern, so depression, substance abuse, despondence, whatever, to qualified help on average is 11 years. So from onset, which is predominantly in adolescence, to care, which is young adulthood, is an additional cost for comorbidities and other issues of $1.8 million per individual. And these are causing delays to adulthood. This is affecting our economy. And when we're top heavy with our age right now in this country, we need production out of our youth and we need a healthy population. And this is a disaster waiting to happen. Well, it's a disaster actively happening. So as we look at our ability to, with GeaCom, to penetrate deeper into the enterprise market with its slow adoption rates, it seems to us that we can supply an innovator in that space in the enterprise and supply Althing and have the greatest impact. So GeaCom being the technology supplier with Fraser Kitsune, predominantly supplying Mayo Clinic and Althing Clinic. And our goal right now is to continue, the innovation of Mayo and what they want to achieve for equity and for efficiency, while we concurrently expand the AIRS program and the Althing Clinic services beyond the borders of the state of Minnesota and the upper Midwest.
Yeah. Wow.
Yeah, well, one of the things that I'd like to point out is that our schools are not like they were when I was there. I've been out for a while, obviously, and these kids care. These kids understand the struggles that their classmates have and that they have. And their schools feel like war zones. They don't feel safe. They feel like they're at the center of a lot of anxiety, at the center of a lot of politics, and they don't want that. And so part of what we do isn't just identify health issues. We identify cultural interactions between students. Is one of these
Okay.
students struggling, being bullied? Are they threatening or are they dangerous in some fashion? Have they made other, for any number of reasons? There are challenges between them and the staff, maybe things that haven't been actively identified. How do we find those and how do we mitigate those effectively? And how does that ultimately not only assure the health and the development of that student body, how does it overall provide greater safety and security for the entirety of that community? So over the last couple of these services we've done, we've worked with the judiciary, so to help them understand where substance abuse and depression are affecting their population. And we're beginning to work with the emergency services to provide AIRS for adults. So assess, intervene, refer, and service for firemen, firewomen, police department, for social services to try to create a healthier overall environment and change the dynamic of a community entirely.
Yeah.
In an aspect of this, I'm sorry to expound slightly, we have direct admitting privileges to most of the medical centers in this state, but we also place our clinics everywhere we go. So those individuals who would like a referral and they're in a medical desert or maybe one that's too exposed, right? A small town 100 miles from the next town, it's hard to get healthcare privately. We provide them a health clinic. We embed that clinic in that community as a part of our service. So
How does that work? I mean, where's the both the provider and the payer and the facilitation between all of that coming from?
So we do completely embedded clinics, meaning that they self-stand up. You don't have to do construction in a building. So if you put it inside of a city building or inside of a college or inside of a school district, it's a self-standing thing. It's called a med bay, the Althing Med Bay. And that entity, when you walk into it, immediately identifies 14 of your vital signs and immediately has 60 decibel noise canceling and provides a private encounter for an individual. Then our technology, the Fraser Kitsune, is in there with that patient. And as I shared earlier, it's the top 50 chief complaints are 100%, embedded in this. So directly to health record, directly private, walks that patient through that encounter. And then we have rotating staff visiting each of these communities. That we don't believe that pure virtual or pure portable clinic services are proper communication theory. We do ensure that our staff spends significant time face-to-face as part of a rotation.
Yeah, that makes a lot of sense.
Technology assisted site. It's not, again, this is where we get into a proxy, right? How do you do that? Is it like a tablet? It's not like a tablet. You are literally having an encounter with a physical individual in a way that is zero reading and writing. It's a very different experience. So we do it utilizing Sight, the technology that we developed.
Yeah, and because they're both the provider, the patient, all of the members of the care team are using the same technology.
Correct.
So that in itself is, like you were saying earlier, it's equalizing what the nurse or receptionist or the doctor is doing.
Self-onboarding is automatic. Social medical primary history is automatic. This stuff runs on its own, but there's a little bit more to this that a podcast wouldn't do justice to. But in the interface that the providers have, we have what's called the Althing Provider Cockpit, where they have these incredibly unique interfaces that help them track the progress and where that patient needs additional help. So the information theory side, as I mentioned earlier, what's a care plan that this patient can effectively execute? Goes well beyond just cultural cues and the care plan that they can effectively execute. It also starts the process of adjusting dynamically with the assistance of a provider, those encounters for that individual. So these are real-time adaptive encounters for that patient guided by a qualified provider that are automatically charting. So these things function in a way unlike other health services, but still
Yeah,
fall within the confines of proper health encounter, meeting regulatory requirements.
yeah, amazing. Well, kind of collecting some of those thoughts and things. Um, what kind of advice or tips would you offer to people who are probably in the tech sector versus the healthcare side, but on the tech side, who are struggling with their own businesses?
Well, obviously, and I think you probably have other people say the same thing, being able to effectively communicate the value proposition is key. I think I am not a fan of the elevator pitch. I am a fan of somebody saying, I want to convince you it's worth hearing this, and I'm going to share with you a little more sophistication. The ability to do that. I really would love to break the elevator pitch model. I think it puts us to very mundane, very cookie cutter type technologies and growth, not towards sophistication. But that's my point of view. The second one is, funding in this state and this region is extremely difficult. Stay well within the confines of funding. If you're going to inherit a lot of shareholders, you're going to inherit the complexity of having a shareholder population. You're going to have some that help, some that hinder unintentionally. That your shareholders have rights and you do your best for them in any way you can, but there's a cost. Try to partner everywhere you possibly can to reduce the burden on fundraising and look for partners who benefit from your existence and your growth. That's another thing I would recommend.
Yeah. Yeah, the interesting thing about breaking the elevator pitch is, again, almost back to the communication theory of kind of mental bandwidth and our increasing desire to compartmentalize and put things into boxes that we understand. Can be a
Yeah, and
challenge.
it's hard to do something special or new without a proxy. And the elevator pitch lends itself to very innovation-based things, right? So one of my good friends, Art Fry, who invented the Post-it note, points out that, there's not many things that are new to the world, so people are not prepared for that. So the elevator pitch is saying, there's nothing new in the world. You can't do anything special. You can just do adjustments that are special. And it breaks the potential of our market space and our innovators when you have to operate in that confine. So I think the elevator pitch is to make the case of the value, and then the actual pitch follows with the sophistication. You should be able to make the value case in minutes. So
Yeah, it makes sense. Well, thank you, Matt. It's been wonderful and fascinating and kind of inspiring of ideas having you on the podcast here. I appreciate it greatly.
thanks for having me. It was a good experience. I haven't done one of these before, so real pleasure. Thanks.
Well, absolutely. Thank you. And for the folks watching the podcast here, when you're faced with challenges and struggles and opportunities in your own businesses, consider some of the journey, consider some of the things that Matt's been sharing here. And as always, you can, approach me for coaching and training. And I'm Steve Semler, FocalPoint Business Coaching, helping techies be great leaders, finding the profit opportunities and the ways to expand and grow your business as you look into those financials and things too. So look forward to seeing you in our next episode. Thanks much.